Hello, welcome to our program. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma Health Sciences Center, and I'm going to share with you today some slides and cases from the realm of soft tissue pathology. Specifically, we're going to talk about the spindle cell and pleomorphic soft tissue tumors, one, both, or neither sorts of approach. To help understand some of the differential diagnoses and entities that we can encounter in general surgical pathology and to some degree in specialty surgical pathology in this realm. So hang on to your hats. Let's take a dash through some of these. And this session is going to be divided primarily into two parts. We'll cover first some of the benign lesions, and then in our second part, we'll cover some of the malignant lesions that are encountered, or at least some of the lesions that may be considered potentially malignant. Recognizing that as we think about differential diagnoses in these locations, the malignancy, the location, the degree of pleomorphism, internal, external, extremity, deep, superficial, et cetera, these lesions have somewhat different presentations and differential diagnosis depending on where you are and so forth. And so understanding that clinical background is very helpful. And we don't usually think, for example, of nodular fasciitis when we see it in a deep location within a body cavity, for example, or associated with a mucosal lesion. But there are other lesions which we will, and hopefully we'll be able to clarify that type of differential as we go through this presentation. So let's begin with some of the benign lesions, the well-behaved spindle cell tumors. And actually the first one on our list is nodular fasciitis. This is a lesion that occurs most commonly in younger people, or maybe early middle age, tends to involve the upper arms, the trunk, tends to be rather superficial, usually subcutaneous, occasionally down to the level of the fascia, but very, very rarely would be involving muscle, although some intravascular lesions have been identified as well. The classic description of this lesion is that of a tissue culture appearance. Now, not many of us do tissue culture, and so what does that mean? Well, it means that these cells grow with a streaming, spindle-shaped appearance with a lot of loose, watery tissue in between. Mitoses tend to be frequent, and there may be some hyaline fibrosis that can be seen as well. More recently, we've identified that these lesions are associated with USP6 gene fusion or rearrangement, which can be a useful marker if we're considering the differential of a more serious lesion. So I've linked with these some digital slides, and that's what the QR code is. Here we see a low power magnification of one of these lesions. It is in the subcutis. And you'll see that while it's relatively circumscribed, it is not entirely clear cut. It has some extension out into the fat. And here's that sort of appearance of a very amphiphilic appearing lesion with a little bit of streaming appearance, spindle-shaped cells with some admixed scattered inflammatory cells in the background. There are a number of examples that I've included here, and these were not always in the QR codes, although sometimes the QR code will link to a series of slides. But certainly the links to the presentation with all the digital slides will be in the description, and you can come back and take a look at that. You'll notice here that we do get some more mature collagen in this lesion, but again, a very loose appearance, occasional extravasated red cells, the appearance of some inflammation. These can all be clues that will be useful to help you make the diagnosis of nodular fasciitis. So something that enters into the differential with that, but has a somewhat different presentation, is the pseudosarcomatous myofibroblastic proliferation. And that is because this is something that occurs primarily in mucosal sites, especially in the GU tract. It was, I think, first described as a postoperative spindle cell nodule occurring post-TUR in some patients with prostatic hyperplasia, and hence it tends to be more adult patients. These lesions tend to be exophytic, polypoid, rapidly growing, and they may bleed. So here's the link to the slide. Immunohistochemistry, not particularly specific, although negative S100, negative CD34 can be useful in excluding some of these other lesions. And as noted here, they will have some myofibroblastic markers. Here's an example of one of these lesions, this sort of piecemeal chipped out, occurring in that sort of a setting where postoperative proliferation was most likely. And again, you see this very tissue culture-like appearance, very similar to nodular fasciitis, sort of blocky nuclei. And if you had this under your own microscope, you would no doubt be able to identify some mitotic activity in this fairly rapidly growing lesion. These do not have an invasive potential. They tend to be benign and will not cause symptoms aside from the bleeding and mass effect that we've alluded to here already. Another lesion, somewhat different presentation, and which we presented in another setting, is the myopericytoma. And you can see this is a more pink lesion. The ground substance has this sort of myocytic type of character. And notice the round balls that this is forming. So it has this weakly nodular perivascular type of appearance. Again, the link to the digital slide if you want to examine that on your own phone. Here's an image, again, underscoring this nodularity in the lesions, and very bland appearing cytology, very uniform, not much in the way of pleomorphism, a bit of vasculature in the background, and often at the center of these little nodular areas is this thin-walled vessel. Now, this lesion is in a spectrum of disorders that includes the myofibroma, which has a more fibromatous type of pattern, the pericytic lesion, the myopericytoma that we've described here, and something with a little bit more glomangial type of proliferation, glomangiopericytoma. All of these lesions are probably part of the same spectrum of disease and tend to have in common this PDFRG mutations. These are painless in contrast to leiomyomas or angiomas, which are usually painful subcutaneous lesions. And they occur in the same distribution in the lower extremities, subcutaneous, and occasionally in the head and neck. So a lesion that is uncommonly encountered, but that can, again, has quite a distinctive clinical pathologic presentation is the phosphaturic mesenchymal tumor. And here's the QR code to a nice example of that. As you see, this has somewhat of a spindle-shaped mesenchymal appearance, but it also has these sort of chondroid areas, a lot of sort of myxoid chondroid-like tissue in these lesions. And here's the example of one that is actually occurring in bone. One thing about these lesions is that they present typically with long-standing vitamin D resistant osteomalacia. And in that setting, they can be the cause of fractures, pain, various metabolic disorders, derangements of the calcium and phosphate axis. And here you see in this example, a not terribly spindle-shaped lesion, but a lot of sort of myxoid cystic changes, a little bit of a mesenchymal field, not really organized as a epithelioid lesion, but sort of vaguely reminiscent of that because of the cystic mucus-like substance that fills some of these cystic spaces. And as you see here, it often can occur in bone, but also can be present in the extremities more frequently. This is also has a fusion gene that's responsible for this lesion. It's usually a fusion of FGF1 or FGF23 that contributes to the lesion that we see here. Remarkably, resection of these lesions leads to complete resolution of the metabolic disorder. In some of the soft tissue lesions, these can have hemangiopericytoma-like vessels, sort of thin-walled, ectatic, and branching or dilated vascular spaces that are the descriptor of the hemangiopericytoma-like lesions. This lesion particularly doesn't have a lot of giant cells, but sometimes you can see giant cells, multinucleate cells in these lesions as well. The myofibroblastoma is also very similar to a lesion that occurs in the breast under the name of spindle cell lipoma or other areas. It is often a mammary type lesion and tends to occur in the milk line most typically. We've given a previous video on this, which the link of which you'll see here or in the cards. And here's a representative digital slide for you to examine. As expected, this lesion has a myofibroblastic immunophenotype with a mixture of myeloid markers, and here you can see this nice collagenous background to this lesion. So these cells may stain with myeloid markers like smooth muscle actin or muscle-specific actin, generally not with desmin and other more or caldesmon that would be characteristic of smooth muscle markers. Generally fairly well circumscribed, this one occurring in the breast, as you can see here. But as I've mentioned, they can occur along the milk line. Here's one that occurred in the vulva. And you can see some variable degrees of myogenic type appearance. So almost resembles a little bit of a leiomyoma with myxoid degeneration in some areas in a lesion like this. We have one more example we can look at here. This is a lesion that is obviously making fat, and hence the crossover with the spindle cell lipoma that we have mentioned and referred to previously. So these fat-producing lesions are also have the same molecular genetics changes that we would expect with the primary lesion. These lesions also usually share a deletion of 13q. I spoke incorrectly. They will occasionally have desmin, and they also tend to have CD34, which, of course, is present in a number of subcutaneous spindle cell tumors, such as dermatofibrosarcoma protuberans and so forth, as well as in solitary fibrous tumors. So there's some overlap with that type of entity, but the desmin positivity would also be helpful in this case. So let's go on to another fairly bland appearing lesion, which is the desmoplastic fibroma or so-called collagenous fibroma. This tends to be in the deep soft tissue, can involve any of a multitude of sites. tends to be more frequent in males, and is usually fairly circumscribed but not encapsulated. This has a very bland spindle-shaped or stellate type fibroblastic appearance with a loose fibrillar background and a sort of a fibromyxoid type of stroma. And this also has a genetic abnormality, 11q12 abnormalities. And recently, people have suggested that this is related to the FOSL1 gene, but that has not yet quite made it to being the definitive diagnostic lesion for this case or this process as of yet. So let's look at a couple of examples of this lesion that will nicely illustrate this pattern. So here's a loosely nodular appearance, somewhat circumscribed, and you can see this very paucicellular, somewhat stellate or spindle-shaped cells, sort of wavy, collagenous background, a few small vessels, and generally low cellularity, low degree of atypia, as you can see here in this example. Another example, again, a nodular pattern, maybe a little bit of central loosening and peripheral hyalinization, a little bit more myxoid here in the center of these lesions, and more collagenous towards the periphery. Some leaky vessels, as you can see. And another example, again, slightly nodular, not terribly descript other than this sort of wavy collagenous background and fairly bland stellate and spindle-shaped cells. So moving on to another very low-grade lesion. This is the nuchal type fibroma, which again has a very characteristic presentation, that being at the posterior neck in middle-aged adult men. This is a very low cellularity lesion with very thick hyalinized collagen bundles and some bland spindle-shaped cells. There tends to be this somewhat characteristic cracking artifact between the collagen bundles, which, if you know to look for it, can be very helpful. Otherwise, you might easily gloss over it. Sometimes you'll find entrapped nerve bundles as well. And here's the digital slide to sort of indicate this. Here you see a few vessels. Do we have any entrapped nerves here? Well, there might be a little entrapped nerve right there. And here you see this very low cellularity collagenous tissue with a degree of cracking here. You can see this almost parched earth kind of pattern of cracking in between the collagen bundles that sort of makes that characteristic change. So looking for those characteristic changes can help you to make this diagnosis, but in fact, the location, the history, those are usually pretty strong markers for this diagnosis. Of course, if you fail to make that diagnosis, it's not the end of the world, as it's not going to recur. So here's another lesion that can also occur on the back, although this lesion tends to be in women. And again, it's fairly low cellularity, but notice as we come in here, notice these bead-like, slightly more eosinophilic fibers in here. So this is a very characteristic lesion that is occurs in a subscapular location, occasionally bilateral, in usually mature women. That is the elastofibroma. And if you are fortunate enough to have access to an elastic tissue stain, you can make these elastic fibers stand out dramatically, as you see here. But even if you don't have that ability, refractive process of your racking down the condenser can help you to bring out these elastic fibers, or even just routine close examination will reveal their presence, because they are really present in dramatic abundance in these lesions, and are not hard to find. They're just require that you know to recognize that they're there and assess them for what they are. Of course, it's nice to have the confirming stain, and I've given you a nice slide of that here to include in your ability to examine or think about these lesions. The elastic tissue fibers stand out with a nice black silver-based stain. There are other stains for elastic tissue as well. However, even such things as crystal violet and so forth can bring out that component. So the next lesion we'll talk about is the calcifying fibrous tumor. And this lesion, again, is a benign lesion, not something that typically presents as a diagnostic difficulty. But this is a lesion that is usually in younger population, children and young adults. It tends to be painless and often involves the deep soft tissues. So you see it's very low cellularity, but a characteristic feature is the identification of these calcifying samoma-type bodies in the lesion. And this is a lesion that, again, has some CD34 positivity and may have some rare Desmond positivity, but generally is negative with myogenic markers. So it'd be hard to put it into that myofibromatous category. So here's a representative slide. And in this particular slide, the calcifying areas are quite rare. Here's one here, nicely highlighted with the dots. Probably one that was here. And I think there was one other one here, over here, perhaps. Yeah, right here you see the one we imaged for the lead slide here. But I have another example of this lesion with more of these calcifications. And here you see it's very, very sharply circumscribed. And here you can see far more of these calcified areas and this very bland background. Now, many of these calcifications will be samoma-like because they tend to occur in these sort of rounded nubbins of tumor, sometimes associated with vessels, sometimes not. Sort of in these little areas, as you see here. Here's one that's sort of incipiently calcifying in that location. To my knowledge, these are not specifically associated with any known syndrome or genetic abnormality, but it may be that we just haven't studied very many of these. So our next lesion is the angiofibroma of soft tissue. This is not the same thing as the cellular angiofibroma, the GYN tract, nor the same thing as nasopharyngeal angiofibroma, which are similar in name, but not the same lesion. I was unable to find a really good slide for this. However, my colleague Jared Gardner has given a nice little digital slide example in one of his videos here, so I'd refer you to that. This tends to be a subcutaneous or deep mass, a little bit more frequently seen in females, and it has this very characteristic collagenous, slightly myxoid stroma with a very delicate vasculature that's quite intense. It's a rich vascular network here. It's not just occasional vessels, but they're really quite dense within these things. And rarely you can have a few HPC-like vessels in these lesions. And this, again, is associated with a particular fusion gene that we see as AHRR-NCOA2. So we'll just move on quickly from that one to the next lesion. which is the deep fibrous histiocytoma. This lesion is a deep lesion, but can also be subfascial or subcutaneous. Adults, usually a few more males than females. There's generally very little matrix in these lesions, but there can occasionally be a more dense osteoid-like matrix, as you see here. And that even on occasion can lead to the form osseous metaplasia, which may raise the differential of, myositis ossificans or even potentially extraosseous osteosarcoma. So this is a lesion to pay some attention to. There can be some atypia and occasional mitoses. So ferreting this one out can be a little bit of a challenge. So here's our representative slide from this lesion. As you can see, generally encapsulated, but a little bit of a, oh, I meant to move this one. This is actually not that lesion. This is an angiomatoid fibrous histiocytoma that's occurring in a node. So I'm going to just let you study that on your own. This is a more characteristic, similar process in a node. So I don't have a good slide for that. I apologize. All right. Well, so the differential diagnosis, as we've mentioned, can include the solitary fibrous tumor, mammary type myofibroblastoma, cellular schwannoma, soft tissue perineurioma, giant cell tumor of tendon sheath, dermatofibrosarcoma protuberans, and unclassified sarcomas. We would add to that if there's very much osteoid, extraosseous osteosarcoma. So just a challenging diagnosis and probably not one to tackle without some good consultative review with your colleagues and others who see them more frequently. You got to remember that in pathology, this is a team sport. And there's nothing at all embarrassing or wrong with sharing a case with a colleague and requesting their opinion. Because that is how we all get better and how the patients get the best care. So let's talk about solitary fibrous tumor, which is certainly one of the more frequently encountered tumors of spindle cells in the soft tissue. Now, this is a situation where the historical evolution is particularly instructive because prepared minds are better able to understand and make connections. And this is the advantage of a diverse education. So this was a lesion that was first identified as sort of fibrous mesothelioma, a solitary fibrous mesothelioma occurring in the pleura mediastinal areas. However, over the course of my career, various people have made their own careers out of describing this lesion in new and additional sites. In fact, I myself have published its appearance and differential when it occurs in solid organs such as the pancreas or the liver. And now there's virtually no site in the body that hasn't had multiple cases or series of this lesion described as occurring there. The spectrum of the disease can include, however, malignant processes as well, though the malignancies are decidedly less frequently identified, but maybe up to 10, 15, 20% of cases. Fortunately, lately, we have also been able to identify that this characteristic fusion gene involving STAT6 will produce a characteristic positive reactivity with the anti-STAT6 immunohistochemical antibodies. And that's very helpful in confirming the diagnosis of this lesion because this is quite specific. Of interest, this is also a tumor that has some association with paraneoplastic syndromes. Here's a nice video talking about some of these other cases, but I also have included here several examples, including a couple of malignant examples for you to consider, and that's what that QR code will link to. But I think the instructive thing is that, you know, if you learn the differential diagnosis for solitary fibrous tumor in its various morphologic types, you'll really learn almost all of spindle cell tumors. Tremendous amount of information can be gleaned from just considering what these various differentials include. So, for example, if you have a myxoid lesion, the myxoid tumors can include low-grade fibromyxoid sarcoma. And what are you going to think about in terms of that? Low-grade malignant peripheral nerve sheath tumors. What about cellular myxoma or myxoid dermatofibrosarcoma protuberans? And giant cell fibroblastoma, myxoid liposarcoma, and rare cases of myxofibrosarcoma with a low-grade appearance. Now, usually myxofibrosarcoma is a high-grade malignancy. So, and likewise, the more cellular ones, a very broad differential that includes several of the things we've already talked about, spindle cell lipoma, and so forth. Some of the things we'll talk about later, like cellular schwannoma, synovial sarcoma, malignant peripheral nerve sheath tumor, desmoplastic mesothelioma, spindle cell melanomas, poorly differentiated carcinomas or spindle cell type, dedifferentiated liposarcoma, and even the phosphaturic mesenchymal tumor can enter into the differential of several of these. So look through these and consider how you would distinguish these different tumors. Of course, none of these lesions that we list here will have STAT6 positivity. So there's a key differential right there. But there are other features, especially if you don't have access to STAT6, that can be useful in considering that differential. And this is, of course, particularly important with needle biopsies or small biopsy samples. So let's look at some of the spectrum of the disease as we think about this. If we do have malignant lesion, it is important to remember that 20 to 30% of those can metastasize. And the criterion for malignancy is mitotic activity greater than 4 per 10 high power fields. All right, so now we get to the digital slides and some of the variants that can be seen. So there is a giant cell rich solitary fibrous tumor. Looks a little bit like some of those other lesions we've described. Fat forming solitary fibrous tumor looks a little bit like spindle cell lipoma, so you can see how that would enter in. Meningeal solitary fibrous tumors certainly can look a lot like other meningiomas. Dedifferentiation and so forth in this tumor can look like other tumors with dedifferentiation like liposarcoma and so forth. So here we go. In the subcutis, here's a lesion. It has some sort of less cellular, more cellular areas. You see this sort of spindly appearance. Some small vessels, some slightly dilated vessels, some of which are more angiectatic or otherwise. Here's some more cellular areas, even with a degree of pleomorphism, as you can see here. So you could consider things like schwannomas or especially with this sort of less cellular, more cellular areas that you see here in the differential here. Looking at another example. Here's again a sort of a chorded pattern, very ectatic staghorn type vessels. So this is the type of lesion that was previously referred to as hemangiopericytoma, with this very cellular pericytic proliferation around these thin-walled ectatic vessels. But very little atypia here, very low mitotic activity. Not a lot of collagenous tissue. We sometimes describe ropey collagen in these lesions, but that would be, you'd be hard pressed to find that in this particular lesion, which this may actually even be a frozen section, a little bit of artifact here. Now, why is this in the spindle cell differential? Well, even though it's not very spindly, it does tend to have some of those features. Here's again a lesion with very large ectatic vessels. You can see here. These are the hemangiopericytoma-like vessels. And here we begin to see some of the other features that are often associated with this, which is this twisted rope-like collagen fibrils. So they tend to be wavy and somewhat twisted together. Here you see there sort of ropey pattern collagen in this lesion. But you could certainly, entertain the consideration of a deep fibrous histiocytoma or other lesion like that. And this might share some immunohistochemical findings with those in terms of CD34 and so forth. These lesions will also often express BCL2, but the more useful marker is STAT6. Here's another example, sort of shelled out. And you see here there's sort of a pattern, but it's really not a definitive characteristic pattern. So sometimes people have used the term patternless pattern. It looks like it ought to be something, but it's not really herringbone. It's not really fascicular. It's not really schools of fish. It's not doesn't have the Verricae body type of lesion sort of pattern, and so it gets its own non-name name of the patternless pattern. But you can see variable cellularity, variable degrees of spindle cell change, a little bit epithelioid changes, and so forth. Here's another example. A little bit more spindly here in this lesion. Again, you see ectatic vessels. This does not have a lot of pink staining material, but actually I think some of this is kind of ropey collagen in between these cell bundles that's just not stained well with the particular stain used by this laboratory. And here's another example. This is occurring in the lung, as you can see here. Fairly uniform, not particularly worrisome for malignancy in this case. I don't see mitotic figures. So even though it's obviously involving the lung, resection of this lesion should result in a good outcome. And you can see these, again, very dilated ectatic vascular type spaces throughout this lesion in this patternless pattern background. I think we have an example. Another lesion, again, you see sieve-like vessels, ectatic changes. Less cellular areas, more cellular areas, and a little bit of intervening collagenous tissue. So we'll skip this one and this one as well, but you can come back and study these on your own. This is a nice example of the specific staining with STAT6. As you can see, it's a nuclear stain, and virtually all the cells should stain with this marker. So here's the characteristic immunohistochemical finding and the associated H&E stain from this particular sample. Okay, well, let's go on to fibromatoses. And these, again, fall into a couple of categories that have somewhat different clinical and pathologic outcomes, even though they share this common name. So superficial fibromatoses, sometimes called Dupuytren's contractions if they're palmar or plantar, Peyronie's disease if they're occurring in the penis, and I'm not sure what the acronym is for those over the knuckles. But these are fairly common and increase with the age of the patient. There's no known APC gene or CTNNB1 mutations involved with this, but they do tend to have some trisomies or loss of Y that can be seen. Now, why you would ever need to do immunohistochemistry, I don't know, because these are very characteristic microscopically. But should you need to raise that consideration, these will have some myofibroblastic markers with SMA and Desmond, but will be negative for CD34, S100, and beta-catenin. They do have somewhat of a recurrence risk in some patients. Now, the deeper lesions are the ones we're really concerned about, and these are often go by the common name of a desmoid tumor. They occur primarily in the abdominal wall, especially in women, in the intra-abdominal cavity, or in the limb girdles in young to middle-aged patients. So those are the main locations. These tend to be less well circumscribed and have, again, variable cellularity, and occasionally these sort of keloid collagenous areas. In contrast, these tumors are about 80% beta-catenin positive with immunohistochemistry. And if negative, due to poor sensitivity of your immunohistochemical stain, you can do genotyping to see if they've got the CTNNB1 mutation or some other mutation, such as in the APC gene that is identified. Rarely other markers within the Wnt signaling pathway can also be seen. Now, this is an important consideration because in general, this is no longer a surgical disease, but is something that's quite eminently treatable with medical means. And that is, in fact, the preferred method of treatment now. So making this diagnosis on a biopsy becomes quite important. So let's take a look at some examples of this lesion. First, here's the superficial type occurring in the soft tissues of the palm, and you see areas of low cellularity with slightly increased cellularity in some adjacent areas. Here you see here, and fairly fish-like rounded spindle-shaped nuclei, fairly uniform and bland in appearance. Now this looks very similar to what you see in the deeper varieties of this lesion. As you can see here, one that's adherent to the bowel. Again, it's a very bland cellularity, fibrillar background, and these sort of wavy nuclei associated with this lesion. So it's not terribly atypical or descript. There's maybe a few scattered mast cells or other inflammatory cells in these lesions as well. Let's take a look at another example. Here's one in the subcutis, probably from the abdominal wall. And you can see this variable infiltrative pattern as it extends towards the deeper soft tissues. And as I mentioned, fortunately, you shouldn't see this type of specimen again, because this is kind of a historically valuable section to understand what's going on with these lesions. And hopefully now, as we have specific therapies, targeted therapies, we can make this diagnosis on a needle biopsy or other sample, and the patient should be able to resolve the lesions without having to have disfiguring surgery. So just to think about this, when we're thinking about the desmoid lesions, in the mesentery, this may be an indicator of Gardner syndrome. Those patients would not be usually CTNN1B and NB1 mutated, but would have the APC gene mutation and have familial polyposis. These long sweeping fascicles, bland spindle-shaped cells, blood vessels, collagen, And as we've mentioned, the immunohistochemical findings are characteristic, but not present in 100% of cases. And so additional follow-up mutational testing may be important. So we'll go on to another benign lesion, the conventional schwannoma. This occurs in generally middle age, males and females equally affected, and generally is in the subcutaneous tissues, but has a very wide distribution. There is some association with neurofibromatosis type 2, which we'll mention here in just a moment. And this lesion has very intense, strong positive S100 staining. Very important feature. It will also be positive with SOX10, occasionally with GFAP, and generally negative or variable with keratins. So we've got a digital slide for you to review as well. But before we do that, I will just refer you, if you're an avid reader, to this wonderful physician-written book called The Covenant of Water, which nicely details an afflicted family with NF2. And I will admit that that's a bit of a spoiler alert, but I think as the story unfolds, you'll find it fascinating to learn from that. One of my favorite books from the prior year. Okay, so going on here, here's a nice example, a fairly large tumor. We see, again, areas of low cellularity, higher cellularity, so-called Antoni A and Antoni B regions, and this very nice wavy spindle cell process. Here's the less cellular area. Fibrillar background, not a collagenous background, a very fibrillar background, as you can see here. And now this may have a few admixed mast cells as well. I don't see a whole lot here, however. Some of these single cells may be mast cells. We've got another example here. This is an example from an enteric site. And in that location, you will find that this little cuff of lymphoid inflammatory cells can be quite helpful as a diagnostic feature. So if you see a needle biopsy from a mural mass in the GI tract and you've got this little cuff of lymphocytes, don't just jump right to GI stromal tumor, but consider that as a potential marker of schwannoma. And gastrointestinal schwannomas are one of the subtypes that can be seen in this lesion. Not as common as other types. Now here's a very cellular schwannoma with a bit of a myxoid background that you can see here. So this would have another interesting differential diagnosis with potentially other spindle cell tumors of the subcutis. And here one from the intracranial region. You can see again these nice spindle-shaped cells. This is a lesion that may occasionally produce Verrucay bodies, but only in a small percentage of cases. So if you don't find them, it's not doesn't negate the diagnosis, just as finding them doesn't always solidify the diagnosis. And of course, Verrucay bodies are where you get the nuclei lining up in parallel with one another, forming sort of a picket fence array. Here's another example. Again, areas of low cellularity, higher cellularity, Antoni A, Antoni B, and a very, very fibrillar background. So we begin to see some atypia in some of these lesions. It is important to note that that's not a significant finding in terms of predictive malignancy. We know that with age and long-standing lesions that there can be quite a degree of atypia develop. The so-called ancient schwannoma is notable for its high degree of nuclear pleomorphism. Again, another example, variable cellular areas. And an additional example, we'll skip through that. So when we think about the differential diagnosis of these schwannoma tumors, probably the most significant one to be concerned about is the cellular schwannoma, where the differential can include solitary fibrous tumor, thymoma, especially if we're in the mediastinum, monophasic synovial sarcoma, malignant peripheral nerve sheath tumor, as well as a number of other malignancies, including spindle cell melanoma and carcinoma. Of course, with spindle cell melanoma, there could be quite a bit of immunohistochemical overlap, as with melanotic schwannomas. So this spectrum of disease involving melanoma or melanocytic tumors is an important one to be cognizant of and to be careful in your differential considerations with it. So just a brief mention of the gastric schwannomas, much less frequently than the GI stromal tumors, with palisading hyaline vessels and this peripheral cuff of inflammatory cells that we noted. Easily distinguished using immunohistochemistry from the GIST, as well as from the other things in the differential, such as inflammatory myofibroblastic tumor. So we'll sort of finish up this section by looking at another nerve-related tumor, and that's the neurofibroma. This tends to be almost exclusively or at least in the most common form, as a cutaneous lesion, where it may be multiple and so forth. But if a patient is afflicted with neurofibromatosis type 1, they will also tend to have a host of deeper lesions as well that can occur anywhere in any organ and create consternation in terms of radiographic evaluation and even clinical biopsy evaluation of various sites. These also will be S100 positive, but only in a minority of cells, and they should have CD34, some epithelial membrane antigen, and the presence of neurofibrillary protein. So here's a nice example of a cutaneous lesion, not terribly dissimilar from that cutaneous schwannoma that I showed you, but less sharply demarcated, a little bit more vascularized, but difficult to distinguish in some circumstances. Now, of course, in the skin, not terribly critical to make that distinction, but it's nice to get the diagnosis correct, especially if the patient has multiple lesions and neurofibromatosis is a consideration. Here's another lesion, again, in a cutaneous location, very poorly demarcated, and sort of a diffuse type of process. You can see this tumor forming process with low cellularity, a few admixed inflammatory cells, and a very diffuse plaque-like appearance of this lesion. Here's another example. Again, there's a bit of a demarcation, but it's not terribly sharp. Fairly cellular lesion, a little bit of atypia, This, again, could be difficult to distinguish from solitary fibrous tumor, from the schwannoma that we've mentioned before, and potentially other spindle cell tumors in the skin, fibrous histiocytoma, and so forth. So here's where your immunohistochemistries come in, and getting the characteristic findings can be very helpful in establishing that diagnosis. A couple of other examples. This is one where we have a neurofibroma here, as you can see here, and nice wavy nerve fibers here. But then we have an altered area here associated with this where the cellularity is much higher. There's a little bit more atypia, some nuclear irregularities. The membranes are less smooth. There may be some mitotic activity here. And so this is, in fact, a malignant peripheral nerve sheath tumor that is developing out of this neurofibroma. Now, that's not terribly common per se, but it is something to be concerned about. Here's another example where we have probably here the underlying neurofibroma, and then this very highly cellular proliferation of spindle-shaped cells, and so this just gives you an example of the spectrum of this disease that you can consider. Now, in this situation, these neurofibromas are universally associated, especially where you're developing malignancy, universally associated with pre-existing nerve. So here's one of the markers for telling you that that's what you're dealing with here, is the fact that you have this entrapped nerve. And you also still have this somewhat fascicular pattern of a large nerve here associated with this lesion. So whether this was coming out of the sciatic nerve or some other related peripheral nerve, it has clearly developed a malignant capability. And I always have to look up the stains that we would use in this situation, but if your memory is better than mine, you'll write it down and always remember it. For me, I could write it down a dozen times and I probably still would not remember it. So with that, I think we're going to stop the presentation, this first part of this presentation, and thank you. Again, the link to this slide, to this presentation, the digital slides and so forth will be in the description. And we hope that you enjoyed that and that you'll come around next time as we talk about some of the malignant lesions that we can see in the category of spindle cell and pleomorphic lesions, in addition to those that we've already discussed today. So till next time, thanks so much for joining me.